chairpersons are ready, we can start with the first presenter, please. Dr. Ms. Indira Pegu. So you may start with your presentation.
Good afternoon, everyone. Myself, Dr. Indira. Today, I'm going to present my study on upcycle smartphone for screening posterior segment disease in the community, bridging the gaps. We don't have any financial interest. So globally, 1.1 billion people suffer from visual impairment. And out of it, posterior segment diseases form a significant part. Only diabetic retinopathy and glaucoma itself are estimated to involve 160 million and 118 million respectively by 2040. But unfortunately, 47 of this population still remains in rural area, and there is delay in diagnosis and referral because of financial barrier, inaccessible healthcare, unavailable trained ophthalmologists. So what is the solution? The solution is screening of posterior segment pathology with a cost-effective method like fundus camera. So there are already studies which have showed that fundus camera can increase the detection and referral of posterior segment diseases both in the campsites and vision centers. So our target was our outreach sites and vision centers. So there are already several fundus camera in the market. Some are tabletop, some are portable, but definitely cost is a factor. So we need an economical solution, especially for LMIC countries like us. And then we came across one device called as iLike device. It's a brainchild of Samsung and LabST, Korea. So what is this device? The device is made up of a recycled polycarbonate material, and the images are taken from an upcycled smartphone. And only additional need is the lens and 4 rechargeable batteries. So in this study, we compared the graders finding using the iLike fundus camera images and compared with the pre-operative and post-operative fundus findings recorded our electronic medical record. And we included all the post-op cataract surgery patient operated at our tertiary care hospital visiting our outreach, and exclusion criteria was any kind of media opacity or patients who were not willing. So total of 811 images were obtained from the period of March to October 2023, and the grader was masked to any kind of previous posterior segment diagnosis. So at the outreach site, we updated or uploaded all the patient details like name, age, the address and the vision of the patient and any kind of systemic history, and even uploaded his consent form. And the trained technician took the dilated fundus image. And all the data were uploaded in the iLike app. So at the base hospital, all this data was downloaded, and the grader opened up all the images and graded it ungradable or gradable and gave a diagnosis. And the investigator compared these findings with the preoperative and POD1 at the EMR record. So graded either gradable or ungradable. Ungradable was usually because of poor dilating pupil or uncooperative patient. These are the few images taken from the iLike device. So 811 images were obtained, and more than 93% were gradable, which is a very significant number. 29 cases were diagnosed on preoperative or POD1. But iLike fundus camera was able to diagnose 52 cases, that is 6.41% of the population. So, and surprisingly, 23 cases were newly diagnosed, including ARMD, glaucoma suspect, BRVO, and macular scar. So this graph shows that how the iLike fundus camera could detect all kind of posterior segment diseases. So our study detected around 6.41% of posterior segment pathology, and this indicates a high potential for this device for screening, diagnosis, and referral at the early stage. So we already know that fundus camera are user-friendly, easily available, and cost-effective. But our additional advantage of iLike device is that it's portable, gives good quality image, uses rechargeable batteries, and it's environmentally friendly and reduces the carbon footprint. Our study expresses the transformation potential of an upcycled smartphone as a powerful tool in the community healthcare. Further studies are needed to validate this device. These are my references. Thank you. Maybe we can give back to the society. At the same time, we can be environmentally conscious. Thank you.
Any questions from the judges?
How frequent do you recharge the batteries?
Ma'am, usually for one camp it works, and in one camp we take around minimum of 50 to 70 images we can take.
So one camp, one set of batteries.
Yes,
lasts.
ma'am. Yes, ma'am.
Thank you.
Yes, ma'am. Thank you.
Okay, we'll call upon the next speaker, please, Dr. Diksha.
Good afternoon, everyone. The topic of my presentation today is to assess the availability of low vision assistive products in the schools for blind in North Bihar. There's no financial interest, no conflict of interest. Introduction: education is the most important tool for social, economic, and political transformation. Schools are the place where children learn and develop many academic activities, improve their self-esteem and cognitive function. India, the second most crowded nation, is home to the whopping one-third of the world's blind. The fact is that in India, many children with disability do not enroll to schools. Such children are usually ignored and inherently neglected from going to the schools due to many reasons. The World Bank reported that children with disability in India are 5 times more ignored from going to the school than children without disability. Illiteracy rate among children with visual loss is around 80% in India. Another study from developing nations showed that literacy rate among the blind and visual impairment was low. In India, students with visual disability study in the special schools for blind. The schools for the blind are designed based on the assumption that children with visual impairment require some special additional resources for academic learning that could not be met in the mainstream or regular schools. Low vision aids or low vision assistive products are devices that aid the people with low vision and allow them to use their residual vision for better living. Low vision assistive products work by making the objects appear bigger, brighter, and blacker or more closely with improved contrast. Examples include, for reading purposes, large print books, optical magnifiers, writing, braille slate and stylus, mathematics, abacus, talking calculator, mobility, walking canes, guide canes, games, braille chess, daily living devices, color detector, talking weight machine. Materials and methods. A cross-sectional descriptive study was conducted in the 7 schools for blind in Bihar in the month of August and September 2023. The principal or the head teacher of each school was interviewed in the study about the availability of the assistive technology as well as the trained human resources. A study tool consisting of 24 assistive technologies was developed for the study. It was further subcategorized into the 7 different domains as reading, writing, math, sciences, games, mobility, and activities of daily living. A color pictorial booklet of the assistive technologies was also prepared along the study tool to avoid any confusion about terminologies of the assistive technologies during the interview. Broken assistive technologies were not included. Verbal consent was taken from the respective principal before the interview. Data management and analysis was done in the Stata 14. Data was analyzed descriptively. Confidentiality of the data was maintained throughout the study period. Anonymity of the data for school, including the availability of trained human resources per se, was maintained throughout the study period. The results are like these. The large print books available were only 2 out of the 7 schools. Optical magnifiers 5. Braille reading books were 7. Electronic magnifier aids were 1. Typoscope was 1, Braille note taker was 1, Braille slate and stylus was 6, Braille typewriter was 2, large print computer keyboard was 1, adapted paper was 5, tailor frame was 5, abacus 6, talking calculator was available in 4 schools, Braille ruler 2, Braille compass 2, Braille protractor 1, walking cane 7, symbol canes 1, tactile dice 2, Braille chess 2, large print games 3, audible cricket balls were only 3, color detector was in 1, talking watch in 6. This is the bar graph showing the low assistive products in the percentage form, and this is the picture showing them. Discussion: the present study reports the poor availability of assistive technologies for the visual impairment in these schools for blind. Braille materials like books and slate with stylus are widely present in these schools for the reading, writing, and training. The poor availability of the visual and tactile and sound-based assistive technologies will hinder the students in further learning or delay in cognitive development skills in the related disciplines, for example, math, sciences, games, etc. A lack of availability for children walking canes and mobility trainers will hamper the students to participate and commute to other school indoors and outdoor environments, for example, classroom, library, etc. Few probable reasons for the poor availability of the ATs are due to the lack of awareness among the teachers unable to afford for the assistive technologies or lack of productions at the local level, etc. However, further studies required to assess the factors for or reasons for the poor availability of the assistive technologies in these schools. There is a huge shortage of the trained human resources, especially for the orientation and mobility, sciences, and maths in these schools. This may be linked with the widespread lack of the assistive technologies in the schools, resulting less demands for the ATs for visual impairment. At the end, the conclusion is children with visual disability not only need assistive technology for their educational activities, but also for their future empowerment and employment. There is a widespread of lack of the assistive technology in these schools for the blind in North Bihar. Also, lack of orientation and mobility trainers in these schools will make the students difficult to manage daily movement and assessing the school facilities independently. Thank you.
It's a really good study.
Thank you, ma'am.
And one thing is like nowadays the normal schools have got special educators. Did you look into that?
Pardon, ma'am.
The normal schools have got special educators now. So they teach 3 days a week children in the normal school, then they take them to the special school. So did you look into that?
No, ma'am, that was not included in the study. Only the government schools were there and the NGO-based schools were included in my study. Thank you, ma'am.
Thank you, Dr. Diksha. Dr. Sudha Lam, please, for a presentation.
Can I start? Good afternoon, all. Today I will be presenting my paper on study of adherence to intravitreal anti-VEGF injections in patients with diabetic macular edema. So, as you all know, the incidence and prevalence of diabetes mellitus is on rise, leading to an increased incidence of diabetic retinopathy, resulting in increased incidence of diabetic macular edema, which invariably leads to requirement of multiple intravitreal anti-VEGF injections. And the 5 dimensions of adherence according to WHO are therapy-related factors, patient-related factors, condition-related factors, health system, and socio-economic factors. The aim of my study is to identify the elements impacting patients' adherence to follow-up appointment and the reasons for non-compliance with intravitreal anti-VEGF injections. Coming to objectives, to investigate the relationship between the demographic data and their adherence to the intravitreal anti-VEGF injections, and to understand the extent to which the knowledge about the disease influence their adherence, and to gain insights into perceived seriousness, susceptibility, benefits, and barriers associated with diabetic macular edema. Coming to methodology, patient comes to vitreoretinal department and is a known case of diabetic macular edema who has already taken more than or equal to 2 intravitreal anti-VEGF injections, and the consent is obtained and questionnaire were administered. My questionnaire consists of 3 sections. Section 1 include demographic details, and section 2 include knowledge about diabetic macular edema, and section 3 about health belief model, which includes questions regarding to perceived seriousness, perceived susceptibility, perceived benefits, perceived barriers, anxiety and pain, cues to action, and self-efficacy. Coming to results, out of my study population include 250 patients, out of which 71% are male and 29% are female, and most of them belongs to a middle class. And 29% of the study population are free patients who get a subsidy of 2/3 amount of the treatment cost, and 71% are free, paying patient, and out of which 32% are insured and 68% paid from their pockets. The average cost of injections borne by the patients is about 2/3 of total amount of total expenses borne by the patient, and the distance traveled and the time traveled by the patient is 76 kilometers and 2 hours respectively. The majority of the study population received Avastin, which is followed by Tricort. Coming to knowledge, about 80% of the total study population has a good knowledge about the disease, and 4.3% has no knowledge about the disease. And around 1/4 of the study population agreed that diabetic macular edema is a sight-threatening disease and will interfere with their daily activities. Around half of the study population were concerned about the visual loss due to diabetic macular edema and recognized the importance of regular follow-up. In around half of the study population felt that regular follow-ups and injections were useful and stabilized their visual acuity. Around 1/3 of the patients perceived that positive effects of on the daily effects due to intravital anti-VEGF injections. Coming to perceived barriers, the barriers for adherence in our study, in the present study, includes difficulty in follow-up dates, unaffordability of injections, transportation, fear of injection, impeding general health of the patient. Over a period of time, the anxiety and the fear of getting injection in the subsequent time has decreased. Around 73% of the population got injection because of being prompted by the doctor, by the treating doctor, and getting a repeated counseling. Even though there are many factors for non-adherence, more than half of the patients wants to get a regular follow-up and regular injections if needed. Coming to discussion, the main factors for non-adherence in my study are remembering follow-up data in dates is 84%, and too many injections in 83%, painful procedure in 80.8%, and fear of injections in 71.6%, unaffordability in 60.8%, and transportation in 60.6%, and impending general health in 63.6% of study population. Coming to conclusion, a tailored educational efforts regarding the comprehensive understanding of the disease, the options available for the treatment, and the benefits of the treatment should be should be explained to the patient, and improved pain management strategies like relaxation techniques and distracting methods should be used, and adopt a treat and extend regimen providing the same visual outcome with lower number of consultations for the patients who cannot follow monthly regimens are used, and financial assisting resources, since diabetes is not only related to ophthalmology, it also includes other specialties, and convenient scheduling should be given to the patient.
Can I ask? Yeah, so you have various data, and you have, in the starting, you started with something else and ended with something else. So you said there is insurance, you said free patients. So did you look at that those patients were coming for follow-up better than the paying patients, or multiple visits? No, when we are supporting the patients, are they coming for better follow-up, or are they not coming for better follow-up?
They're coming for better follow-up.
But that's not shown in the results, right? There's too much of data which was scrambled into a shorter period. Thank you.
One question regarding why the patient do not turn up. In the questionnaire, was the question included after first injection if there is improvement? So that also patient.
No, sir, I didn't ask that.
Because that is a very common factor.
Exactly.
Patients get an improvement, they do not turn up.
Yes.
Next presenter, please. Dr. Charita.
Good afternoon, everyone. I am Dr. Charita. My presentation is on incidence, risk factors, role of insulin like growth factor 1 and postnatal growth failure in ROP development in very low birth weight babies. As we all know, ROP is a multifactorial disease, the major risk factors being low birth weight and gestational age. However, local VEGF production and systemic IGF-1 levels play important roles. In preterm birth, there is a rapid fall in serum IGF-1 levels as maternal sources are lost, and there is an initial first phase of ROP where there is a decreased IGF-1 levels. But with increasing postmenstrual age and weight, systemic IGF-1 levels rise, permitting VEGF activity and leading to ROP. Studies in European and American cohorts have shown that low postnatal serum IGF-1 levels lead to severe ROP. However, IGF-1 levels cannot be estimated in all the babies. Therefore, postnatal weight gain can be used as a surrogate measure for serum IGF-1 levels. And there's limited research on the Indian cohort concerning these factors. The primary objective of our study was to estimate the incidence of ROP in babies with birth weight less than 1500 grams and to determine the perinatal risk factors. Also to determine the role of insulin like growth factor 1 and postnatal growth failure in predicting ROP. Sample size was estimated to be 329. It was a prospective cohort study conducted in the departments of ophthalmology and neonatology in JIPMER after IEC approval. The inclusion criteria was birth weight less than 1500 grams and preterm babies less than 34 weeks of gestation. Babies were divided into two categories, ROP versus no ROP, and further classified for intergroup comparison as group 1 no ROP, group 2 mild ROP, group 3A moderate, and group 3B severe and treatment requiring ROP. Weekly birth weight was estimated and monitored using growth charts. Growth failure was diagnosed based on Z-score. 1 ml of blood was collected for IGF-1 levels, centrifuged and deep freezed, and assessed in ELISA kits. So Z-score was calculated at birth, and at 36 weeks, and the difference in Z-score if it was more than 0.8. So if there was a fall of more than 0.8, it was considered as postnatal growth failure. Results, the incidence of ROP was 49.5% in our study, mild ROP 44.4%, and moderate severe ROP 5.1%. Mild ROP had 146 babies, whereas moderate severe ROP had only 17 babies. On univariate analysis, gestational age, birth weight, low weight gain per week, postnatal growth failure, insulin-like growth factor 1 levels, oxygen supplementation, antenatal steroids, small for gestational age, respiratory distress syndrome, low APGAR score, and mechanical ventilation showed statistical significance. The gestational age followed non-normal distribution. The data, most of the babies belong to 32 to 34 weeks of gestational age, and the median gestational age for babies without ROP was 32, whereas it was 30 for babies with any stage ROP. And birth weight distribution, around 52 babies were extremely low birth weight, and the group with babies having any stage ROP had a lower median birth weight of 1100 grams compared to the group without ROP. It had 1230 grams. And babies with any stage ROP had a lower median weekly weight gain compared to the babies with no ROP. The weight gain was 91.6 grams per week in any stage ROP group. And IGF-1 levels, it was estimated only for around 186 babies due to logistic and medical reasons. And also the median IGF-1 levels were lower in the babies with any stage ROP, 18.82 nanogram per ml, compared to no ROP group with a median value of 28.8 nanogram per ml. Postnatal growth failure was found to be more in the babies with ROP. On multiple logistic regression, only serum IGF-1 levels showed significance. And area under the curve for IGF-1 levels was 0.627 with a cutoff of 25.56 nanogram per ml, indicating it to be a fair indicator for predicting ROP. And the area under the curve for weight gain per week was 0.621 with a cutoff of 107 grams per week. Discussion. There are various studies, previous studies comparing IGF-1 levels, and our studies had similar values, and it's one of the first study in India to estimate serum IGF-1 levels with the largest sample size of 186 babies. And weight gain per week values also were comparable with previous studies with a cutoff of 107 gram per week. Limitations, collection of 1 ml blood for IGF-1 estimation was difficult, so we had missing data. So along with the established risk factors, lower weight gain per week, postnatal growth failure, insulin-like growth factor 1 levels were the additional important risk factors analyzed and noted to have association with ROP. Our study analyzed 186 babies for IGF-1 levels, one of the largest sample size and first in India with a cutoff of 25.56. However, future studies establishing prediction models with these is required. Thank you.
I've got just one suggestion. You are putting from stage 1 to 5 together. So stage 1, the ROP grading is less, so their weight will be more. So you should have 5 categories and then you should compare. Instead of, from 1 to 5 together you're comparing. Stage 1, how many children had a birth weight high? Stage 2, definitely stage 5 children will have a less birth weight.
Actually, we do not have any stage 4 or stage 5.
You don't have
babies.
at all?
Like in this, only up to stage 3.
Why?
Babies. Like in the screening perspective. Thank you.
Thank you, Dr. Charita. Dr. Suprita, please.
Hi everyone, good afternoon. My paper is on pediatric outpatient department based vision screening in children in a tertiary hospital. So pediatric vision screening is a crucial part of primary healthcare, and vision plays a major role in a child's development. The common ocular disorders that we encountered were refractive error, amblyopia, convergence insufficiency, strabismus, etc. So the pediatric OPD has not been commonly used as a target area for vision screening programs previously in India. So aim of our study was to assess the benefit of utilizing pediatric OPD as a target area for screening in children. So all children from the age of 1 to 16 years who visited the pediatrician's OPD underwent the screening. So a pocket vision screener was utilized and other additional tests were also performed. Children who had failed the screening tests were referred to the ophthalmologist, And more than half of the children did not review with the ophthalmologist. So they were interviewed via telephone to analyze the reasons. So the screening was done using a pocket screener, and the children were read from a distance of 3 meters. And in preschool and pre-verbal children, central steady and maintain method was utilized. For squint evaluation, Hirschberg corneal reflex test and cover tests were performed. To assess the extraocular motility, we used the H technique. So, the results of a study were in total 800 children were included, and the age group was 8 years plus or minus 4 years. The gender was almost equal, and around 84% of the children had only passed the test, and out of the 127 children who had failed, only less than half of them reviewed with the ophthalmologist. So some of these children were symptomatic, and the common symptoms were headache and blurred vision. Others were frequent blinking and eye irritation. So some frequent systemic associations were developmental delay and speech delay. Around 1% of these children had strabismus, and exotropia was found to be twice as common as esotropia. And other incidental ocular pathologies that we came across were amblyopia, nystagmus, lid swelling, unilateral 6 cranial nerve palsy, and Duane's retraction syndrome. So out of the 127 children, 69 of them did not review, and on probing we realized that the most common were loss of follow-up and unwell child, and other reasons were some of them took appointments for a later date and some were consulting elsewhere. So the study which is currently there in India was started in 1994, and the screening of middle school children. And by 2018, the primary school children were also included in the screening program. So some of the other studies we had compared were Sukla et al. Was a study done in primary school students. Here the drawbacks were the secondary school students were not included, and teachers found it difficult to examine preschool children. And a study done in Udaipur was done in government school setup and did not extend to private schools. And there was another study done in AIIMS, New Delhi, which was done house-to-house screening in 40 different clusters. This study was very cumbersome and a large manpower was required. And there was logistical issues. The Modest et al. Was the first instrument-based screening which was performed, and it had improved rates of complete vision screening, and it reduced largely the unnecessary referrals to specialists, and family satisfaction was superior. So the existing studies, the reported referral rates from 4 to 14%, whereas in our study, which was performed by trained ophthalmic assistants or optometrists, had higher referral rates, about 15 to 16%. However, the dropouts from reviewing with the ophthalmologists were almost similar to the previous studies. In several countries, it's mandatory that the children undergo screening from birth to preschool age and periodically thereafter in a pediatrician clinic. However, this practice is not common in India. So, in conclusion, we highlight that almost 1 out of every 6 child that visited the pediatric OPD failed the screening process, and we analyzed that more than half of these children did not review with the ophthalmologist, the common reasons being loss to follow-up and child being unwell. So, to the best of our knowledge, this is the first Indian study to look at the pediatric clinic as a target area for vision screening and to identify vision problems in children. These are some of my references. Thank you for your patient listening. I would like to take this opportunity to thank AIOC and my consultant Dr. Gayatri J. Panikar and my HOD Professor Radha Namrai for guiding me through this process. Thank you.
Any questions on the judges?
No, sir.
Thank you.
Next is Dr. Shruti Nayak.
Good afternoon, everyone. My study is on retinal nerve fiber layer thickness in Alzheimer's disease and its relation to cognitive function. I have no financial disclosure. Alzheimer's disease, it is the most common form of dementia worldwide, which will affect 1 in 85 people globally by the year 2050. And there is deposition of abnormal proteins like amyloid plaques and neurofibrillary tangles in the cortical areas and the medial temporal lobe structures in brain. As the retina is a peripheral extension of the CNS, the neurodegenerative changes of Alzheimer's disease also reflect in the retina. OCT is a non-invasive technique, which is a standard imaging technique in neuro-ophthalmology. So we can use the changes in OCT measurements in the retinal layers and optic nerve. It will serve in diagnosis and monitoring of neurological diseases such as Alzheimer's, Parkinsonism, and multiple sclerosis. The aims and objectives of the study is to study the association between circumpapillary RNFL thinning and cognitive impairment in Alzheimer's disease. It was a cross-sectional hospital-based study which included 40 right eyes of 40 patients who were sent for ophthalmological evaluation from the Department of Neurology. The mini mental status examination scores of 19 to 23, suggestive of mild Alzheimer's disease, were selected as cases, and 40 age-matched randomly chosen people without other neurological complaints were selected as controls. We excluded people having refractive error of minus more than 5 diopters, axial length more than 25 millimeter in that eye, and history of other known retinal diseases like glaucoma, ocular hypertension, and media opacities that will hinder OCT. History of other neurodegenerative disorders or other clinically diagnosed dementias were excluded. As history of other cerebrovascular accidents, these patients were also excluded. We did the following evaluation after informed consent and history taking. Best corrected visual acuity was recorded, slit lamp examination, biometry, IOP by applanation tonometry, fundoscopy, and SD OCT scan was performed. Coming to the results, the mean age of cases was about 72.5 with a standard deviation of 4.478, and the mean age of controls was 70 years with a standard deviation 3.76. This is how we calculate the mini mental status examination, and between 18 to 23 is suggestive of mild cognitive impairment. And we found significant thinning in the circumpapillary RNFL thickness in the Alzheimer's disease group compared to the control group in the global and the temporosuperior quadrants, as evidenced by the p-values, which was less than 0.001. This is the SD-OCT of a patient showing the thinning in the temporosuperior and the global quadrant. Coming to the correlation factor, we calculated the Spearman's correlation coefficient, and the mini mental status examination scores showed a positive correlation with the circumpapillary RNFL thickness globally. R value was 0.52, and in the temporosuperior quadrant, R value 0.34. Coming to the discussion part, circumpapillary RNFL thinning occurs in all quadrants in Alzheimer's disease according to a study, but in our study we found that it was reduced in the global and temporosuperior quadrants as compared to age-matched controls, and there was thinning in the global and the temporosuperior quadrants as evidenced by other studies. Some studies like Seri et al. And Otkem et al., they found that MMSE scores do not have significant association with macular volume, but not with the circumpapillary RNFL thickness. But we found association between the MMSE score and the circumpapillary RNFL thinning. And retinal thickness was associated with the MMSE scores of Alzheimer's disease patients according to Kim and Kang et al., and our study also agrees with them. Coming to the conclusions, we conclude that retinal thickness measurement by OCT could be a biomarker of mild cognitive impairment in Alzheimer's disease, and by instituting early treatment, we may be able to slow down the progression of dementia, thus improving the quality of life of the patient. Thus, OCT can be a boon in the clinical evaluation of dementia associated with Alzheimer's. The study had certain limitations like small sample size, and our cases were recruited from the Department of Neurology based on clinical diagnosis and MMSE scoring, and however no amyloid marker testing was done, thus we could not increase the accuracy of the diagnosis, and further longitudinal studies are required which can shed further light on the areas regarding nature of the circumpapillary RNFL thinning and cognitive decline in Alzheimer's disease. Our take-home messages: OCT could be a novel, non-invasive diagnostic tool in neurological, specifically the demential diseases, and there is a scope that OCT could be helpful in the early diagnosis of dementia associated with neurological diseases. These are my references. Thank you.
Can you show the slide exclusion criteria slides?
Yes. It's not working. It's not working. Yes.
Why you exclude that reflect on the basis of reflection and the axial length?
So because myopic eyes, they have a large disc which can mimic glaucoma, and they have the retinal nerve fiber thinning.
And refractive error? And axial length be same?
Same. Thank you, sir.
Next is that Dr. Praveen Vashi
Not coming. Yeah, respected judges and delegates. In fact, I would like to talk about the National Trichomotor Trichiasis Survey, which has been conducted with the support of National Program for Control of Blindness. In fact, trachoma is still the leading cause of infectious blindness globally. But in Sierra region, India is the only country which has not yet declared trachoma free by WHO. And in fact, we are signatory to Global Elimination of Trachoma Program by WHO since 2000. And a lot of initiatives have been taken since 1959, including this latest, this 2014-2017 survey, in which we found that trachoma among children, that is 0 to 9 age group, prevalence is just 0.7%. And as per WHO criteria, if the prevalence is less than 5%, it is taken as eliminated. So Government of India, they declared trachoma among children is eliminated in 2017. But when we talk about adult population, specifically for trichomotor trichiasis, which is seen in 15 years above age group, the prevalence was 3.5 per thousand in 15 plus age group. And as per WHO criteria, if the prevalence is less than 2 per thousand, only then we can declare it as TT free. So in fact, we invited the WHO team in India to declare what is the status, what we have to do. The national program team, WHO team, all of us together had a meeting. And they guided that first we have to show that in all the previously hyperendemic areas, we need to show that safe strategy have been implemented. And beside this, we also have to train the team members and then need to conduct a survey, a TT only survey, which is as per the guidance of the WHO in all the previously hyperendemic states and districts in the country. And they said now TT has been defined separately, the cases of trichomotor trichiasis which are unknown to health system, only those cases need to be considered. Those who are known to health system, that means either recurrence is there or they are already booked for surgery or seen by the patient, they are not to be covered. And they guided that there are 200 districts in the country and which need to be covered for survey, 200 districts, and as per their survey methodology, 3,000 people need to be covered in each district. So sample size of 6 lakh people need to be examined, only then we can request WHO for declaring elimination of trachoma in India. So we take this initiative, RP Center for Ophthalmic Sciences. The aim objective of this survey is to assess the prevalence of trichomotor trichiasis, including blindness due to trachoma in the previously trichomotic endemic states in India, and identifying the TT which is unknown to health system. In fact, WHO Tropical Data Group was partner for this thing. They initially conducted training of our trainers, and then our trainer further conducted the team members. At a time, 6 different teams were going on 6 different districts, and we plan to cover this survey in 2 years of time. Sample size, as I mentioned, is 3,000 of 15 plus age group. In each district, we have identified randomly one evaluation unit of a sample of a population of 1 to 2.5 lakhs, and entire data is actually entered in a smartphone-based software. It is Android software, which is again given by the WHO. And in each district, we have randomly identified 30 clusters, and in each cluster, 35 households have been examined. So approximately 100 to 150 people were covered in each cluster of the districts. And in examination, our aim was to identify trichiatic lashes, whether upper lid or lower lid, and also if trichiasis is there, then presence of scarring in upper lid. Of course, the quality assurance was well maintained. It was by RP Center. The data was sent to in our software, and from there our team was cleaning the data, and on daily basis we are submitting data to WHO Tropical Data Group. I'm happy to share that that survey has been completed in 200 districts. We have examined 7,30,239 people. You can think of how big is the survey. 88.84% is the coverage. Population were examined. The number of TT cases identified 162 in all these districts, just prevalence of 0.25 per thousand. So against a target of 2 per thousand, we have got 0.255 per thousand. And this is the status of blindness. Of course, blindness is almost negligible because of trachoma. Even corneal opacity prevalence is also very low, 0.14%. So we can easily say that trachoma is actually eliminated in our country. Against a target of 2 per thousand, it is less than 0.2, it is 0.25 per thousand. It is a big achievement for our country, but it is not a process like it can be declared by our country. We have to submit a dossier to WHO for this purpose, and we plan to, in fact, there is a task force now. I am member secretary for the Government of India for that task force. We are having a meeting for it. A dossier will be prepared and submit to WHO, and then we'll request WHO to declare this trachoma is eliminated in our country. Thank you very much. Thank you.
It's a very nice presentation, sir. And was it done during the COVID period because everybody was wearing a mask?
Yeah, we started like somewhere between 2021 September. The project was given to us in March, but because of COVID, we had to delay it by 6 months.
Right.
But even at that time, precautions were taken.
Thank you.
Thank you.
Thank you, sir. Dr. Kaushik, would you
Good afternoon, seniors, teachers. I'm here to present our study which uses generative AI as a chatbot to support patients undergoing cataract surgery. Cataract surgery is the most common surgery performed worldwide, but however, there continues to be apprehension among patients. They are looking for timely, trustworthy information, but they know that it's a challenge to reach out to doctors in person every time, and finding reliable information online is always a challenge. Technology has been used widely in healthcare, from using robotic process automations and administrative tasks to some chatbots that have been used earlier. And OpenAI's ChatGPT has been shown to be able to address both patient queries and also enable professionals access information. So our aim was to see whether we could develop a WhatsApp-based ChatGPT-powered bot that could reduce preoperative apprehension and anxiety in patients and improve their experience. We included those who were coming for cataract surgery for the first time. They had to be literate and had to obviously access WhatsApp above the age of 18. They filled an onboarding form which included them filing out a Likert scale score about what they thought their anxiety was. The bot was built in support with Microsoft Research in India. This used an Azure AI language translator because we realized that most of them would be visually impaired and would want to probably voice record their messages. So this was made available in the 4 common languages that is 5 languages that's spoken in Bangalore. We used GPT-4 to classify the question. This then went to the doctor or counselor, whether it was medical or logistical. The ChatGPT went through a curated knowledge base which had content that we had uploaded into the system and gave up an answer on an average between 4 to 7 seconds. But the same answer was also pushed to the doctor and counselor, and if they marked the response as correct, it came up with a green tick, and if it was wrong, they made a correction and that got corrected. I'll show you a short video that'll kind of highlight what we had done. These 2 screens show the point of view of the patient and the other one is the point of view of the doctor. So here you see the patient actually type in a question saying that when can I take a shower after surgery? This is a very commonly asked question, and almost instantaneously an answer should pop up on the screen now. Where it says that you can take a shower, you will see a small question mark there that indicates that this was generated by the bot. The doctor gets the answer that the bot has kind of generated, and it also tells them from where the answer has come. Meanwhile, they put yes, and the question mark has changed to green, and the bot also triggers the next 3 questions they can ask. We've had as random questions asked as saying that how can I eat biryani or how early I can eat biryani. So we had about 258 users that you asked these questions in a variety of languages. Of them, we found that a large number of questions were actually asked by the attenders, and 85% of them had asked at least one question. This ranged from surgical procedure to medication, pain, and recovery. A majority of the questions did not require an intervention from our side. A lot of them needed only some missing information that needed to be done. And when we looked at the anxiety score before the bot was used, it was about 3.4 that dropped to about 0.32. And on an average, there was about a 1.5 drop in the Likert scale pre to post intervention. So what we've realized is that cataract patients do have an amount of anxiety, although not very high on the Likert scale, and this ranges based on various studies anywhere between 11 to 80%. Information is provided to all these patients by either the doctor or the counselor, but often there is a chance of misinformation being provided by the staff or a misperception, and also studies have shown that there is a limited retention. So with this, we looked at a two-stage LLM-based bot that could actually provide a verified answer. Even our previous deployments where we've looked at AI, the patient always wanted a human being to tell them what was happening. So this is the first of its kind tiered model where the patients and attenders have an advantage of an instant response that does get validated over a period of time. Patients were extremely comfortable because they knew there was a doctor at the other end or a counselor who knew the subject was validating the responses. And with this, with over a period of time, as the knowledge base got updated, our intervention also kept coming down. This, of course, has a limitation of being tried only in a condition. We've now expanded it to a couple of other conditions, and we did not, in this particular study, look at why 15% of them did not ask a question. We assumed that they did not have any questions to be asked, and therefore they did not look at it. In conclusion, this is the first possible GPT-4-based chatbot, which is able to aid in creating answers to patients' questions by drafting responses that can actually be reviewed by clinicians. It alleviates anxiety and apprehensions and makes the patient journey for cataract surgery much more comfortable. Thank you so much for your time.
Nice study, sir.
Thank you.
Thank you, Dr. Bashir. Dr. Aisha, please.
Good afternoon, everyone. My study is on the smart vision glasses for the visually disabled, the patient's perspective. There's no financial disclosure or conflict of interest involved in this study. Coming to the introduction, blindness being a very functional burden is an umbrella term which is used to define people with visual impairment worse than 3/60 according to WHO. Globally, there are at least 2.2 billion people who have vision impairment, and of these, at least 1 billion people have visual impairment that could have been prevented or is yet to be addressed. The quality of life in a person with blindness further reduces when the vision is hand movements close to face to that of no perception of light. Although many assistive devices have been tried for these patients with total visual impairment of 100%, there's always been scope of improving the assistance that could be provided to these patients. These digital assistive devices available for patients with total visual impairment are few, and many are not affordable to the patients. Now, coming to the materials and methods which were used in the study, we did a cross-sectional study which was conducted over a period of 6 months from February 2023 to August 2023. 40 patients who were fulfilling the inclusion criteria were included in the study, and their feedback was taken according to the Likert scoring system on the 4 parameters which I'm going to mention. So now the Likert scoring system, 1 stood for very dissatisfied to that of 5, which was the patients were very satisfied. Now coming to the smart vision glasses, so basically this is an assistive device which is attached to the side of like regular looking glasses, and it captures images and then gives the vocal commands on what is there in front of the patient and helps them in reading, walking, and seeing the things around him, and for facial recognition. Now the methodology, so this device needs to be connected to the smartphones with a type C or B type of cable, and requires a smart vision app to be downloaded in the phone. And the inclusion criteria which was used for this study were patients who were willing to give consent, and patients with visual impairment with vision ranging from hand movements close to face to that of no perception of light. The exclusion criteria were patients who were not willing to give consent, patients with hearing impairment, patients with intellectual disability, patients who were not affordable for smartphones, and who do not have access to internet services. Now this is just a small clip on how the device functions. So you give instructions to the patients and it captures the images, and then it tells it out loud. The audio is not playing. Yeah, so this is the reading assistance which is provided by the glasses. Then this is for identifying objects in front of them. So it captures the image and then it tells that there's a black cup which is in front of the patient. It can recognize up to 100 faces and store it in the system. And it also helps in walking assistance and helps the patients in identifying any any obstacle which is there in front of them. The observation and results. So we did the study on 40 patients, and majority of the patients belong to the age group of 11 years to that of 40 years, with 13 patients belonging to 21 to 30 years. Now, these are the diagnoses of patients who were given a trial with smart vision glasses. Majority of the patients were with bilateral optic atrophy of 22%. 21% of the patients had bilateral phthisis bulbi. 11% with macular scar. 8% with locomatous corneal opacities. 11% with advanced glaucoma, and 19% with advanced retinitis pigmentosa. Out of the 40 patients which were studied in our study, 86.25% of the patients found the device to be helpful, whereas the 90% of the patients found the feature of recognizing the things around them to be helpful. 80% found the walking assistance to be helpful, whereas 90% found the reading assistance, and 85% found the facial recognition feature to be helpful. The overall feedback was that 86.25% of the patients were satisfied with the device. And some of the possible causes which showed unsatisfaction in our patients was that difficulty in learning to operate the device. One was like focusing the camera at the right angle to get legible images. For example, while walking, it's difficult for patients with total visual impairment since childhood to focus at the right angle because they did not look down while walking, and patients were not motivated enough to use the device as they are already used to their walking canes. Now, patients with low vision are often dependent on aids to maximize their ability to orient themselves and perform activities of daily living. And our results indicate that smart vision glasses is a promising device to aid these patients with total visual impairment, although it has a learning curve. And in this study, some of the things that our patients were very comfortable with was the facial recognition feature, recognizing things such as money, I think, which would be very helpful for them, identifying obstacles while walking, and reading also had a very high positive feedback. And in a comparative study which was done in 2019 by Michael Weisbord, it was suggestive that 88.9% of the patients were satisfied with the device, which is comparable to our result. Now, coming to the conclusion, these smart vision glasses, it's a very promising device which could help the patients in their day-to-day activities, as 86% of the patients found the device to be helpful. And patients with 100% visual disability should be motivated to try these devices as they could help them with their day-to-day activities. And this is a preliminary study which was conducted which showed positive results, and more studies are yet to be conducted to assess the quality of patients who are using these devices in a long-term basis. These are my references. Thank you.
Any questions from the judges, please? What is the distance up to which it can reliably tell the patient while walking?
So it has a good, like the range, I think around 3 meters it can recognize clearly. Further than that, yeah, so because of that they have issues in using it on roads. Also the fast moving traffic is not captured by the device so legibly. Thank you.
Dr. Shubhashri Parag.
Yeah, good afternoon, everyone. So today I'll be presenting our study on accuracy of a modified diagnostic algorithm for red eyes. So as we know, red eye is probably one of the commonest symptoms that we see our patients come to us with, and there are a myriad of causes that could cause this red eye. Now, differentiating between these causes is very important because most of our red eye patients would still be treated and handled by the primary care physicians. And why is it important for them to differentiate? Because you know which are the serious ones that need to be referred and which are the ones that you can treat in the primary center. Now, algorithms are usually designed to help novice doctors or training doctors to diagnose accurately. Now, one such algorithm is the Edinburgh red eye algorithm. It's a validated algorithm, and it helps assist non-ophthalmic practitioners in the UK. We modified this algorithm, made it a little simpler for our Indian subcontinent, and our aim for this study was to evaluate this diagnostic accuracy of this modified red eye algorithm, and this we applied to digitally acquired images. Now, it was a prospective observational study, and we had 5 study participants. So we tested this algorithm on 5 participants. And how was it tested? Using a digital repository of smartphone images of 115 patients with recent onset red eye. Now, recent onset meaning within 4 weeks. This was our exclusion criteria. Now, 2 ophthalmologists were considered the experts. We screened the OPD, got the 115 red eye consenting patients, captured their red eye images using a smartphone, and uploaded it with a brief metadata into the digital repository. Now, we use this repository now on these 5 participants. Who were the 5 participants? We had 3 primary care physicians, 1 medical student, and 1 intern. one internist, internal medicine specialist, and we checked their diagnosis with this digital repository and compared it with the diagnosis of the expert. Now, for the purpose of analysis, we split the group of the 115 patients into two groups, Group 1 and Group 2. The Group 1, more serious cases requiring an immediate referral. The Group 2, innocuous conditions. Now, for the agreement analysis was calculated using Cohen's kappa, and we had a sensitivity and specificity of the algorithm to differentiate between the groups, also calculated. Now, this was the modified algorithm that we have used, and these were all the diagnoses that were included. Now, this is just to show you what our digital repository looked like. This was the image with the brief metadata, and this was how we expected the algorithm to be used to arrive at the diagnosis. Again, images showing you how we could have used it. Now, we had 115 patients, out of which in Group 1, which was the serious causes like ACG, keratitis, and iritis included in that, and we had the Group 2 of the innocuous, which was all the other diagnoses. Now, our sensitivity and specificity to differentiate between these two groups was 89.2%, and the specificity was 95.1%. This was our distribution of cases. As you can see, the Group 1, we had keratitis as most number of cases we had was keratitis, and the most common case in the Group 2 was conjunctivitis allergic. Now, our agreement analysis was quite high, especially with the medical student, followed by the internist. This was our Cohen's kappa. It was 0.829 in the medical student, and it was 0.787 in the internist. This was our individual diagnostic accuracy for each of the diagnoses. In Group 1, the highest accuracy was for ACG, but we had just 2 patients. And in Group 2, it was conjunctivitis at 90%. Now, the agreement between our participants and our experts was very high, and it was statistically significant. And the agreement was, as you'd seen, was the highest in the medical student, followed by the internist. Now, the study was actually diagnosed to test this accuracy and the algorithm's ability to make a diagnosis when you're using only images and clinical data. There was a study previously done by Timlin et al. Who used the algorithm, but they had the patients to validate this on, and yet our diagnostic accuracy was similar to theirs. The distribution of cases was similar to other studies, and we had a higher diagnostic accuracy for the innocuous versus the serious, again similar to the other study by Timlin et al. Our limitation is we had a lower incidence of serious cases. This could be because of natural selection. And the metadata may not have been lucid enough for the primary care physicians. We conclude that this algorithm is clinically useful because of its high diagnostic accuracy and its ability to discriminate between the groups. And this would really aid the primary care physicians in differentiating the red eye causes because they will know which are the serious cases that need to be referred. And our modified algorithm would serve as our first step in probably developing an AI tool. Thank you.
Specificity, what you mentioned, 90%.
95, yes.
For Group 1,
No, this was to differentiate between the two groups.
for these red eye cases, we would love like not to miss those cases which
Yes.
actually have to be there, right?
Yes.
So anything about the specificity for glaucoma you mentioned was 100%.
Our diagnostic accuracy was 100%. So that means, yeah, the 2 cases were yes, yes. Yes, thank you.
Swami, visually please.
Respected chairpersons, I will be talking on a large family of congenital bilateral microphthalmia, anophthalmia from Assam. As we know, microphthalmia and anophthalmia are birth defect with small ocular globe and the absence of the ocular globe respectively. It is a significant cause of childhood blindness, not only in the world but also in India. Always it is associated with other ocular abnormalities. Sometimes it may associated with systemic anomalies also. We have studied the cases to find out the causative factor for familial bilateral congenital microphthalmia, anophthalmia in a single family with non-consanguineous marriage. It's a cross-sectional study 37 subjects from a single Muslim family across 4 generations from Assam. Study period is 2018 to 2023. An impoverished family from Rupohihat village, Nagaon, Assam, has been affected generation after generation with a very rare isolated hereditary bilateral microphthalmia, enophthalmia. Out of 37, 19 family members were found to be affected. This is the family photograph. And pedigree chart shows that 19 living members in 4 generations affected with congenital bilateral microphthalmia, enophthalmia. Some of the affected persons in the family. There is also age correlation between the visually disabled and the sighted persons, also in between the male and female persons. The visual disabled person, the percentage is 51% and sighted 49%, male 63.2% and female 36.8%. BCVA of affected members range from hand movement positive to PL negative. That is category 4B visual disability. It's bilateral. The other sighted members are having visual acuity 6, and 6 or better than 6/9 without any deformity of the eyeball. Detailed ocular examinations were done of the affected family members. 2 had enophthalmia, rest had microphthalmia with different type of intraocular structure abnormality like sclerocornea, microcornea, iris coloboma, cataracts, nystagmus, etc. These are the details of the ocular examination of all the family members. A 55 years male member of the family with microphthalmia. We also assess the all those affected persons by a team of comprising neurologists, pediatrician, internal medicine specialists, pathologists, obstetrician, and gynecologists. Were found no other any abnormalities. There is any history of maternal infection, deficiency, illness, or teratogenic exposure in the antenatal period. We have done all the necessary investigation like X-ray face and orbit, NCCT orbit, ASOCT, A scan, and B scan to find out the intraocular structural abnormality and bony orbital cavities, any abnormality. The most important part is the genetic analysis of the whole the affected persons. This is the DNA test report. It is likely to be pathogenic variant causative of the reported phenotype was identified. The results are genetic analysis determined the GJA8 gene mutation at exon 2 location with a heterozygous autosomal dominant inheritance. No systemic association noted in any family member. Bilaterality noted in all affected family members. This kind of familial congenital microphthalmia, enophthalmia has not been reported previously from northeastern India. It's a good sign that there is declining trend of visual disability in newer generations because we did the dedicated counseling, contraception, family planning, MTP of 3 pregnancy after a positive anomaly found in USG antenatal scan. Keeping in mind the cosmetic and social impact of enophthalmia, microphthalmia, option of consultation with oculoplastic and prosthetic services, and DA banking for possible future use also. The ophthalmologist is usually the primary doctor. They can coordinate the multidisciplinary input. Socioeconomic counseling and rehabilitation is of utmost importance. Necessary information sent to the concerned authority. So in conclusion, proper investigation and diagnosis of causative factors of hereditary congenital bilateral microphthalmia is utmost important at least earliest age of life. Patient education and counseling are the primary need. Couples were advised contraception and prenatal testing. PGD may be tried. These are my references. Thank you for patient hearing. Thank you very much.
Nice presentation, ma'am.
Thank you. Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
For the last presentation, on behalf of Dr. Purna, your good name, please?
Dr. Purva Srivastava.
Dr. Purva Srivastava.
afternoon, respected dignitaries on the dais. I, Dr. Purva Srivastav, co-author of this study, will be presenting this study, Incidence of Ocular Ailments in Slums and Rural Areas, on behalf of Dr. Khurram. We have no financial interest, disclosures or conflict of interest. So this study was aimed to evaluate the prevalence of different ocular ailments in the slum-dwelling and rural population of central India and to find its correlation with various socio-demographic factors. So it was conducted as a cross-sectional study in the 84 slum areas across Bhopal. So some areas in vicinity were also covered. The approach was camp-based, and the study period was about of 3 years from 1st June 2017 to May 2021. So study was conducted in different capacities by all the 4 authors participating under different government and non-government banners. And a total of approx 15,000 participants attended these camps, and out of them around 6,248 patients were found being afflicted with different ocular ailments. So detailed data was obtained from the participants of the camps, and it was tabulated later so as to study the correlations. So we recorded the age, gender, socioeconomic status, also the diagnosis that we made and how we dealt with it later. The data was compiled and processed. So we had approx 15,000 patients who were screened for the ocular morbidities using a camp-based approach, and approx 6,248 patients had some affliction or the other. So majority of the patients belonged to 31 to 50 years of age, and maximum patients having some ocular ailment belonged to more than 30 years of age. The morbidities were significantly higher in males. So the most common disorder that we saw was refractive errors across all age groups, followed by allergic conjunctivitis, lid pathologies, pterygiums, and cataracts. So this I have already dealt with. And the least common morbidity that we found was ocular malignancies. Upon diagnosis, we had the option to treat, since it was a camp-based approach, so we did have the option to give them the refraction services. But apart from that, we had them referred to our base hospitals in Bhopal, so where we could operate upon them. So a lot of pterygium and cataract surgeries were done, and some DCRs and glaucoma surgeries were also done. This I've already dealt with, that the major surgical surgeries were done for pterygium. So when we were comparing this with the other similar community studies that have been done previously in the rural or the slum dwelling population, so in other studies also similar statistics of the affliction was found. However, we did have a little bit of contrast with other studies with because of the geographic area that they covered. So basically, concluding idea is that stress should be on the camp-based approach, so we can go on conducting camps, screenings, providing them with the whatever treatment we have at our hands, whatever resources we have, and then referring them to the base hospitals so that these diseases do not get undiagnosed, they don't get untreated, and so that ultimately we can reduce the burden of blindness in the low socioeconomic and rural slum dwelling population. However, we did have our limitations because this was a camp-based study. Thank you.
Any questions from the judges, please? Thank you, Dr. Purva. So this was the last talk of this session. As we conclude the session, I thank all the presenters for sticking to the time and finishing this session on time. And I will request our chairpersons for any concluding remarks.
Thank you all. It's a nice session, particularly the 2 talks from one on the trachoma tracheosis survey, and other one is the cataract bot. Thanks.
Okay, so best of luck to all the participants. And before we conclude, I would like to invite all the chairpersons and the participants for a group photo, please.
Thank you all.